Okay, so this is Parkinson's and anti-Parkinson's drugs, and specifically carbidopa, levodopa, also known as Sinemet. But before we talk about that, let's talk about the actual disease. All right, so I'm going to share my screen, and let's get to the PowerPoint. Which is Parkinson's. Here you go, chapter 28 from the Farm Book. So Parkinsonism is cluster of symptoms associated with it. Tremors, which is shaking, bradykinesia, slowing of movements, ataxia, shuffling gait, tardive dyskinesia, akathisia, choreiform movements, and muscular weakness. Parkinson's disease is a degenerative and progressive disorder. I'm going to say that again, because you're going to hear me use those terms. Degenerative, which means it just gets worse. Progressive, over time. So things break down more and it doesn't ever get any better. It only gets worse. And over time, it gets so bad that it ends in death. And with Parkinson's, when folks pass away from Parkinson's, it's because the nervous activity has gotten to the point where it's so overstimulated that the muscles get rigid. And when that happens, you can't breathe because you need muscles in order for your lungs to expand and contract. So end-stage Parkinson's, the muscles are so rigid from that hyperactivity from the nervous system, they're just like boards. So there's no room for expansion or contraction of the intercostals or the diaphragm or all those muscles that you need to breathe. So they die from respiratory failure. It's caused by an imbalance of neurotransmitters, dopamine and acetylcholine. And those neurotransmitters help with communication in the nervous system with muscles and some other things. And we'll talk a little bit more about them, right? So it's believed that that imbalance of dopamine and acetylcholine is what causes these symptoms. When you look at someone with Parkinson's, there is this little mnemonic device, and it's called TRAP, T-R-A-P. Tremor, right? Shaking. And it usually starts on one side, unilateral. Rigidity, stiffness of the limbs, the neck, the trunk. Akinesia, A means without, kinesia means movement, without movement. So it's a loss or impairment, involuntary movement. And then posture and balance. They have a problem with posture where their balance is so off that the falls are frequent. And then when you look at this poor little old man, see how he's stooped over? Very rigid, forward tilt in the trunk. You know how when you walk, your arms kind of swing? They don't do that. They have this expression on their face, and it's called the Parkinson's mask. Technically speaking, we call it a blunted or a flat affect. But their face really does kind of change in expression and almost stays frozen like that. Their elbows and their wrists will stay in flexed positions. Their flexed hips, flexed knees, trembling of the extremities, shuffling, short stepping gait. You'll see them drooling a lot, right? And really, it's a horrible, horrible, horrible disease. So here's a list of the motor symptoms, because there are motor and non-motor symptoms. So that postural instability, and I put the definitions in here for you guys. It's the inability to maintain their balance. And then there's something called retropulsion. Retro means backwards. So instead of propulsion, moving forward, it's retropulsion. They have a tendency to fall backwards because of that postural instability. Bradykinesia, which is those slow movements. The freezing gait. So what you'll see is it almost looks like their feet are glued to the floor, and patients will say that. So when they go to step forward, they kind of hesitate, like they can't lift the foot or make the foot move to move forward. That's called a freezing gait. So that's in with that rigidity and freezing in place. That stooped shuffling or ataxic gait with a decreased arm swing. Let me move that up some. There's something called micrographia. And this is a weird one. Their handwriting gets smaller, smaller, and smaller. And then they have this blunted or flat affect, that lack of facial expression that's also known as the Parkinson's mask. So make sure you know those terms, okay? Non-motor symptoms, impaired olfaction. In other words, they can't smell. Hypophonic speech. Their voice gets more quiet, like weak. They have sleep disturbances. They can have hallucinations, depression, constipation, drooling, sweating, urinary frequency and urgency. Blood pressure will drop. They'll get dizzy. And there are lots of symptoms that accompany Parkinson's disease. And we break it down in stages, right? Because it is progressive and degenerative. So like I said, we can't stop it because we don't know what causes it. So when we medicate patients with the carbidopa, levodopa, what we're hoping for, best case scenario, is that the symptoms kind of calm down a little and don't get too much worse. So you don't need to know the stages, but this is more of an FYI than anything else. So it starts out with the tremors, and then the symptoms progressively get worse. They can't do things that they normally could do. So stages 2 and 3, balance is lost. They fall. They can't tie their shoes, brush their teeth. Right? By the time they get to stage 4, they're probably not able to walk independently. When they get to stage 5, they're not able to walk at all. They're usually wheelchair and or bed bound, and it's bad, right? So those are the stages. Must know meds. Here's the one you got to know, and it's carbidopa, levodopa. It's also known as Sinemet. I don't like the yellow, so I'm going to do that pretty shade of blue. Adverse effects. So yeah, nausea, dizziness, vomiting. Somnolence means being sleepy. Hallucinations, confusion, visual disturbances, postural hypotension, abnormal involuntary movements, darkening of urine, right, and headache. You see how I didn't highlight the nausea and dizziness and vomiting? Because those things are common with so many meds. So you don't need to keep writing that. Almost every med has the potential to cause that. But sleepiness, hallucinations, confusion, visual disturbances, those symptoms that you see under the adverse effects, aren't they actually symptoms of Parkinson's as well? They are. So here's the thing. Neurological meds, their adverse effects are typically the very thing that they're being used to treat, which is weird, I know, but it just is. Meds that are used for neurological problems have neurological adverse effects. It just makes sense. And most often, and this holds true for seizure meds too, the very thing that we're giving it to you to treat, it can cause or make worse. So that's important to know, okay? All right, so dopamine. I'm not going to get into great detail with all these neurotransmitters, but just like a quick overview. Dopamine is a neurotransmitter, and it helps with the nervous system communicating with the musculoskeletal system, helps with fine motor function, but it also helps with things, emotional things like motivation, finding pleasure in things, and that word is hedonism, right? Compulsionary behavior, like I have to wash my hands twice, I have to. Perseveration, and that's fixating on a thought or idea, and they can't let it go. Why is the sky blue? But why is this? But why? What? And they won't let it go. Can't help it. So dopamine helps control those things, but because of the imbalance of dopamine in Parkinson's, you will see fine motor function is a problem, tremors, motivation, they really don't feel like doing anything. They don't find pleasure in anything. And sometimes we'll have the compulsionary behavior and perseveration in their thoughts, okay? So drugs that are dopaminergic drugs, levodopa, carbidopa, right? Symptoms of Parkinsonism are caused because they don't have enough dopamine in their central nervous system. There is a drug called amantadine. Don't worry about that one. Selegiline. Do you see, though, how they end? The I-N-E. If you look at those words, hopefully, if you do ever see them, you will recognize them. They're different classification of drugs, but they have dopaminergic actions. But the one that you need to know is the carbidopa, levodopa. It's two meds, but when we take levodopa and we put it with carbidopa, it usually has a better effect in helping to manage the symptoms of Parkinson's. So that's the one that you need to know. So we use this to treat Parkinson's disease, Parkinson's symptoms, that can happen like because of antipsychotic drugs or injuries or encephalitis. Remember, encephalo, the brain, itis, inflammation. So an inflammation or infection of the brain. Restless leg syndrome, which, you know, that's a new one that came out about, I don't know, 10, 15 years ago. And dopaminergic drugs, they say help. And certain viral infections, but just, I want you guys to really just focus on the Parkinson's and the Parkinson-like symptoms. They're the ones that we're concentrating on with the use of Med-Carbidopa, Levadopa. So what else can happen with carbidopa, levodopa? Dry mouth, which is xerostomia. Difficulty swallowing, which is dysphagia. I'm actually going to highlight all of that and put a little bit of an explanation in as well. Make it a little bit smaller. So dry mouth is also known as xerostomia, and I'm going to put those explanations next to the words because you need to know them. Oh. Dry mouth, xerostomia. That's not a big deal in and of itself, right? Matter of fact, there are some drugs that we actually use because of the side effect of the dry mouth. We use them in hospice, okay? We'll talk about that later. Difficulty swallowing, that's dysphagia, right? And it's pronounced dysphagia, not dysphagia with the G. Anorexia is not anorexia nervosa, right? We've talked about that. That's loss of appetite. It's not the psychiatric diagnosis, okay? Loss of appetite. And then nausea, vomiting, abdominal pain, constipation, increased hand tremors, headache, dizziness. And then with the levodopa specifically is those increased choreiform or dystonic movements. So whenever you see DYS, that means it's, you know, dysfunctional. It's not working right. Tonic, you've heard of a tonic-clonic seizure. So tonic is the hyperactivity or hyperexcitation of the nerves that cause the muscles to have these jerky, awkward movements. They're dystonic movements or choreiform movements. And of course, and I'm not going to highlight this, don't give it to them if they're allergic to it. That holds true for every drug, right? For levodopa with glaucoma, they should not take it. And this one is important. If the patient is on an antidepressant, that's an MAOI, this is a drug that they should not have because it increases their risk of serotonin syndrome, okay? So the MAOI antidepressants, really the one that you need to know is phenelzine. And that has nothing to do really with this chapter or topic, but that is an FYI. So you can't give levodopa with the MAOIs. Phenelzine is one of them. It's the one you need to know because the patient will have, and I'm going to put in here, will result in serotonin syndrome, which is life-threatening, okay? So, and don't worry about this stuff, okay? Matter of fact, I'm getting rid of that completely. Okay, they give you a table always. I don't necessarily highlight it, but just triunderstand that with these drugs, antidepressants in general, not just the MAOIs, but especially them, but even the tricyclic antidepressants, and the one that you need to know there is amitriptyline, right? So don't give these drugs with the tricyclic or the MAOIs or the SSRIs even, because what happens is it increases the risk of hypertension and dyskinesia. And when we say hypertension, that's one of the cardinal symptoms of serotonin syndrome, right? So that's an important one. Okay. That's the one you need to know. And then don't worry about the action because like I said before, no one's ever going to ask you about the action. And don't give it to somebody that's allergic to it. Again, that's why I don't highlight that. And, you know, again, some of these drugs, I'm not even going to go over this table with you. You're not going to get asked about those. The rest of this chapter goes into a lot of detail about COMT inhibitors, and that's catechol-O methyltransferase, which is something that has to do with dopamine. Don't worry about this. Matter of fact, I don't want to get rid of these, but what I do want to do is I just want to make sure that you understand that slide 16, 17, and 18, and That's it. 16, 17, and 18. Don't worry about those. All right. Actually, I'm just going to get rid of them. Here we go. But back to those cholinergic blocking drugs. So like Sinemet, Levadopa, Carbidopa. So it's what they do, but the antihistamines are also in that group, like Benadryl. Diphenhydramine is Benadryl. So believe it or not, sometimes we will give Benadryl to someone with Parkinsonism or Parkinson's disease because that will help with the symptoms because of its anticholinergic effects, and they have less side effects, right? So just remember that diphenhydramine, because that is an ATI question, that is a Miss Mary question, that is a board topic. So diphenhydramine is an anticholinergic, and it is used for Parkinson's and Parkinsonism, and it's also used to treat extrapyramidal syndrome with antipsychotic medications, okay, in addition to benztropine. So, all right, so let's see. Right, there you go. So what are the uses of them? Therapy in forms of Parkinsonism and in drug-induced extrapyramidal disorders. So they mean EPS because somebody's on an antipsychotic. And here are all the anticholinergic, side effects. Now, with anticholinergic drugs, there's a long list of them. I'm not going to give you the whole list, but in a separate PowerPoint, I'm going to go over the ones that you need to know, like diphenhydramine, oxybutynin, tiotropium, because anticholinergic drugs, which are used for Parkinson's, but they're used for a lot of other things too. They're a weird group of meds. You have meds for overactive bladder in that group. You have meds for Parkinson's and EPS. You have medications for respiratory issues like COPD. You have medications for cardiac issues like atropine. So it's cholinergics, anticholinergics are a weird class of medicines. So even though I'm giving you a little taste of it here, it's going to be its own little PowerPoint and lecture, which we will get to later. All right. So, I'm not even going to get into all of those things because that's in the anticholinergic lesson. We'll go past this. So when you look at the nursing process, I just hope you know at the end of these chapters, this is the care plan. The nursing process, it is the care plan. So before you give the drug, what do you do? And while they're on the drug, what do? You evaluate, like, is it working? Are their symptoms better, right? And then here's some nursing diagnoses. They're always at the ends of the chapters that are associated with Parkinson's and with, Levadopa, Carbidopa particularly. And then, what are the outcomes? Well, is the drug working? Is the patient getting the support that they need? Are we managing any adverse reactions? Make sure they're not getting injured, right? And are they compliant with the medication regimen? And you always want to make sure with any drug, especially neuro drugs, that you're really watching patients like a hawk, because they can be taking the med and all is well, and that can change. I know it's very strange. It's like you would think that when they start taking it, they would have that reaction right away. And you'd say, okay, not the med for you. Not always. Sometimes a patient will be on a medication, especially some of these neuromeds, for a minute, a week, couple weeks, and then start having these adverse effects. So you really want to make sure that you're monitoring patients on neuro drugs. Make sure that they're eating, make sure that they're drinking. If they have dry mouth, the big thing is the sugar-free hard candy, and I'm going to include that here. Otherwise, they will gain a lot of weight. Okay, I'm going to highlight this actually for the dry mouth. Sugar-free hard candy is awesome. And then for the constipation, you're going to, make sure they're getting enough fiber and fluid in their diet. Make sure they don't fall. Help them when necessary. Physical mobility. Sometimes the doctor, and I'm going to highlight this, will give them a holiday, drug holiday. In other words, like a little vacation from the drug. Because remember, we can't stop this disease. It's going to progress and get worse, degenerate. So sometimes they'll start to develop a tolerance to the drug, and you'll start to see the symptoms getting worse again. So we'll take them off of the Levadopa for sometimes 2 weeks to get, let them get off of it and kind of withdraw from it. And then we'll put them back on it, but we'll restart it at a lower dose and kind of work them, build them up again. Okay. Yeah, the rest of this is pretty straightforward. Make sure that the family and the patient understand. make sure that, you know, again, here are the outcomes or the goals, and then there are a few questions at the end. So that really is Parkinson's, Parkinsonism, and carbidopa, levadopa, kind of all rolled in to one neat package. So I'm going to stop sharing and stop recording.